Hi, everybody. Thanks for joining today. We're going to be talking today about prostate cancer discoveries, new and emerging frontiers in treatment of prostate cancer. My name's Matt Britland. I'm the president of a group called MAPPA, which is the Medical Affairs Professional of Australia. We're all drug development medics and scientists who work in the industry to deliver medicines. Very excited today to be joined by an esteemed panel, Associate Professor Prem Rashid, who's a president of USANT's urologist, Dr. Tanya Holt, a radiation oncologist from the Icon Cancer Centre, and Bernard Riley as well, the General Manager of Supportive Care Programs at the PCFA. So thank you for joining us today. We're here to talk about prostate cancer discoveries, new and emerging. Over the past 5 years, the world has seen a real rapid shift in how we manage and treat prostate cancer. This shift has been precipitated by the advent of technologies such as multiparametric MRI, PSMA, PET scan, CT, as well as advancements in prostate biopsy and across the spectrum of treatment from surgery to new forms of radiotherapy and nuclear medicine. To discuss the landscape for survival, I do want to welcome this panel. We're going to dive straight into the topic of the day and then finish with general discussion and questions. So turning first to Prem, thinking back, Prem, over the last 5 years, what would you say the most exciting developments have been in the field of urology for prostate cancer?
Thanks, Matt. The pleasure to be here, and thanks for the invite, firstly. Lots has happened. The word that came up for me when I saw the question that you put to me yesterday was awareness. I think we are now aware about a great many things. If you start from the beginning, things like this type of forum that is available because of the technologies that have resulted from COVID, mean that we can bring together a panel very nicely and put together a presentation for someone to watch at home. That allows people to be aware in the community, allows people to pass this information on to each other. And it means that more and more families, and men in particular, will think about prostate cancer as a disease they need to know about. Because at the end of the day, I think we all know this disease in its early stages has no symptoms. And so awareness of the disease and raising it with their primary care physician, their general practitioner, is the first step. The second aspect, I guess, is PSA. PSA has had a checkered history over time. It has been the result of controversy. But more and more, what we need the community to appreciate is that a PSA should be done by any man who would like to be assessed for prostate cancer, preferably from the age of about 50, early if there's a family history, and then done on a 1 or 2 year basis to check on the change in PSA over time. So awareness of that aspect in primary care. You may know that the general practice guidelines are a little bit confusing with regard to this. Certainly general practitioners tell us that. And so many will not do a PSA because they think, well, it opens the door, opens a can of worms. But that does not necessarily have to be true. I think if you use the test reliably, you'll get some good outcomes. Then if you look at the way we progress from there, PSA leads to usually a urologist giving an opinion about the PSA and an assessment as well as a clinical examination of the prostate. Now we can use, as you say, multiparametric MRI to give us a better idea of the risk of prostate cancer in any individual man. So raised PSA does not necessarily mean that they have prostate cancer. MRIs are used to give us a risk, and then that progresses on to sometimes biopsies in men, where we get tissue diagnosis of the prostate. And that has also changed. We used to biopsy through one channel. We now use a different way to biopsy, and the risk of infection is much, much lower. If you then look at treatment options, then there are a variety of treatment options, current as well as emerging. Surgery has advanced in a number of ways over the years, including the introduction of robotic surgery. But there are also 2 very good treatment options in radiation, which I'm sure Tanya will cover, including radiation that's delivered externally, but also radioactive seeds. And again, it's awareness of treatment options. There are other treatments, which are known as focal therapy, where you treat a specific cancer within the prostate, and that is also available in some centers across the country. For me, that's probably introducing the topic. I will stop there for a moment and let you ask your next question.
Thank you. Thank you, Prem. It's incredible, really, to see the advances in this short period of time. I certainly know I've been involved in cancer for 23 years, and what I've seen in the last 5 years is a little bit like when I saw Steve Jobs, show his first iPhone many years ago in tech. It seems we're a real exponential inflection point, and a great segue, actually. And I think one thing with prostate cancer we know is this is a true multidisciplinary approach. So you've just talked about from a urology perspective, but turning to you, Tanya, and your role as a radiation oncologist in a busy centre, can you tell us about what you see on the front lines of radiotherapy practice and how things have changed for the better?
Yeah, so I thought I might just start as just a little bit of a brief overview of radiotherapy before I talk about the advances, in the fact that obviously radiotherapy, like surgery, is a mainstay of prostate cancer treatment, and it's used in 3 main scenarios. So the first is what people think of most, which is that definitive radiotherapy. So that's an alternative to surgery for men who want to keep their prostate. So we're giving treatment with curative intent. And so the majority of men in Australia, if they have radiation delivered, it's generally in the form of external beam radiation. So that's a radiation beam that's generated from a linear accelerator, and you lay still on a radiation couch and the machine moves around you, and as it does, the radiation enters your body. So it's a highly targeted treatment these days, and precision is measured in millimetres. So I'll talk about that first, and brachytherapy is the other way to deliver radiation, where it sort of comes from the outside in, that Prem was just talking about. So in terms of radiation, sort of advances in radiation delivery, over the last 10 years, those advances have enabled us basically to be able to bend the radiotherapy beam around corners. And so the importance of that is that neighbouring the prostate, you've got the rectum at the back and you've got the bladder at the top. So to be able to bend the radiation beam around the corner allows us to spare those tissues a lot better than we could 10 years ago. And that means that's less side effects for the patients as well. So that type of radiation is called VMAT, or IMRT radiation, and that's very much standard of care these days across Australia. And so in some circumstances, we talk about sort of trying to spare those good tissues, particularly the back passage or the rectum, which sits behind the prostate. One of the other advances that we've seen used a lot more in the last 5 to 10 years is the use of what we call spacers or gel spacers, which is a gel that can be injected by the urologist or the radiation oncologist in between the rectum and the prostate to push the rectum away from the prostate capsule, and that enables us to reduce the dose even further to the back passage and help to reduce side effects further as well. The other thing that has become very much standard of care, which we didn't have sort of 10 years ago, is the use of tracking. So most men, not all men, but most men who have radiotherapy these days will have some small gold seeds inserted into their prostate, again, most commonly by the urologist, but often also by the radiation oncologist. And those 3 little seeds don't have any radiation in them, but what they enable us to do is see the prostate in exactly the position as it is every day, and allows us to track it. So the radiation machine can actually see those little gold seeds, and as it moves around the body, it can see if those seeds, and therefore if the prostate has moved even as much as 1 or 2 millimetres, then we can adjust that setting for the radiation beam to stop if the prostate moves at all. And so that allows us to have a very tight and targeted radiation beam even further than just using that VMAT that I talked about before. And so those 2 new technologies have allowed us to give higher doses of radiation to the prostate and lower doses to the good tissues. And there's a few new techniques which are sort of emerging recently, where we're actually giving boosting to the dominant lesion. So that on the MRI scan, where we can see where the prostate cancer is, or on the PET scan, where we can see where the prostate cancer is. These techniques allow us to sort of get extra dose into those areas where the prostate cancer is at its most dense, and giving slightly less dose to the prostate in adjacent to that. So that's one way. It's another sort of advance that we've seen coming through. The other is stereotactic radiotherapy, or SBRT, and this is a practice or a way of delivering radiotherapy, giving a high dose to the prostate and a low dose to the tissues directly around it. But it also enables us to give it in a lot fewer treatments. So 5-10 years ago, the standard of care for men having radiotherapy was having nearly 8 weeks of treatment So 1 treatment a day for nearly 8 weeks, Monday to Friday. And over the last 5 years, we've seen a number of studies come through that have shown us that giving shorter courses is just as safe. So probably the most standard care these days, unless men have very irritated bladder symptoms when they start, is giving 4 weeks or sort of 4 to 6 weeks of treatment rather than the 8. And this SBRT treatment allows us to even go lower, and sometimes even as few as 5, where men will just get 2 treatments a week rather than 1 every day. And so that new technology, or that SBRT, we've now got studies that show that that's very safe. And for men who have lower grade or intermediate risk disease, where the risk of having cells outside the prostate is very low, that's a very good and convenient treatment for men to have. And that's becoming more accessible in most radiation centres throughout Australia these days. So they're probably the biggest advances in delivery of radiation treatment.
Wow. That's a lot. Okay, so it's very easy to appreciate the importance of providing men then with that range of options for treatment when the prostate cancer is diagnosed. And I suppose if you think about patients now versus 10 years ago, it's a different patient as well, isn't it, in terms of their accessibility to information. And so I'd like to turn to Bernie, who plays a very key role at PCFA. If we talk about exponential growth of these therapies, the nursing side as well has completely changed as a profession. But in terms of helping men and their partners make this choice, Bernie, I mean, how have you seen things change over time?
It's absolutely significant changes in the past, 5, 10 years. And I reflect back to when my father was diagnosed, 13 years ago. The landscape was much different then. He, when he was diagnosed, he was given the option of surgery. There was little discussion about radiation therapy as an option while it was an option. And certainly there was not much support beyond a pamphlet given to him. So, the level of support, has changed significantly in that time. And with the advances in, diagnosis, biopsy, imaging techniques, and these developments of treatment techniques, and clinicians getting much more skilled and aware of options for people. And then we look at men who are diagnosed with advanced disease. The amount of treatment options that are there for men has grown significantly. So the landscape for men has changed significantly, and nursing has changed too. Nurses are now much more educated, and there's more nurses available for support, and more support available for men at that point of diagnosis and beyond. In 2012, PCFA launched a pilot program where 12 nurses, prostate cancer specialist nurses, were placed in hospitals across Australia. And over the past 10 years, that's grown to over 100 nurses across Australia in settings, in rural, in regional hospitals, in metropolitan hospitals, private, public, hospital settings, radiation treatment centres. So we have nurses all over the country now available to support people from the point of diagnosis and onwards. So significant changes there, but we can never have a nurse available in every treatment centre and available at every point of diagnosis. And so, PCFA has also developed that level of support where there's a trained prostate cancer specialist nurses available to take calls from people across Australia, from men and their families worried about a diagnosis of prostate cancer, or concerned about, their risk of developing prostate cancer. And so, people can call and discuss any particular problem they have, and that fills that gap for men and their families, and it also adds an extra layer of support to professionals like Prem and like Tanya. It adds value to the service that they provide. We can give patients and people who call our service a great deal extra time to go through those treatment options, to explain to them exactly what those treatment options might mean, and expand and answer some of those questions they might have, but also arm them with some of that knowledge to go back to their clinicians to further answer questions. So that level of support is significantly changed. But it's not only about, you know, the amount of nurses you have out there and have on the ground. It's about addressing, you know, some of the needs of people. So it's addressing those unmet needs that men identify when they go through their prostate cancer treatments. And, you know, PCFA embarked on developing a psychosocial model of care, and part of that has been something where we're rolling out distress screening across all of our treatment centres for all of our prostate cancer specialist nurses and for clinicians out there who are involved in prostate cancer treatment. And it gives men an opportunity to identify the things that are bothering them the most, a list of problems which concern them. And nurses have undergone specific training to understand and be able to refer onwards and develop, refer onwards to other clinicians, to allied health professionals who are best placed to deliver, you know, evidence-based interventions to support men and support their families through whatever, you know, particular experience they're going through. You know, and off the back of, you know, that distress screening and that psychosocial model of care, PCFA launched this year a counselling service. We're very proud that we're able to provide that service to men and their families, an extra layer of care for people who are in high distress, who have extra needs as a result of their prostate cancer and concerns. And this is about matching, you know, individual needs and problems to the right level of care and evidence-based interventions. And so we have a service of highly experienced nurse counsellors and a psychologist who are trained specifically to address and help people address these problems. And I guess, you know, this further developments in the nursing space, and off the back of the development of the Prostate Cancer Essentials Survivorship Essentials Framework, PCFA and the NHMRC Centre of Research Excellence for Prostate Cancer Survivorship developed the My Personal Plan, a survivorship care plan for men as they are diagnosed with prostate cancer and as they go through their treatment phases. That helps them be at the centre of that care and to give them personal agency, to make them the focus of their care and have a real place in deciding where they would like their care directed, what needs they have, and how they'd like to be best supported. So the face of nursing has changed, and the face of support for men with a diagnosis of prostate cancer has changed significantly over that 10 years since my father was diagnosed all that time ago. So it's fantastic to see better educated nurses and better support for men and their families when they really do need it.
So it sounds like we're not treating the prostate cancer anymore, we're treating the patient with prostate cancer, right? And everything that goes with it. And just quickly, how do people get these plans, Bernie?
So these are rolling out across Australia through prostate cancer specialist nurses and treating centres. So it's something that your prostate cancer specialist nurse, if you have access to one, or through PCFA, calling us, we can help you access a plan like that and help you develop that plan and understand it. So being rolled out now across Australia, just launched recently in trial done throughout treating centres across Australia. and will continue to be, something that is available and utilised by men and their families.
It's great work. So, Prem, I'm going to come back to you. So we want to think about maybe the next 5 years, new advances, nerve sparing surgery, earlier diagnosis. We know no cancer starts at stage 4. It all starts as one cell that splits to 2 to 4. It all goes through stage 1, 2, 3, 4. How do we get there early? Things like PSMA, theranostics. What's the future, the next 5 years looking like from a urology perspective?
Yeah, thanks, Matt. It's an exciting time because there's a lot of research going on. There always has been, but I think we're seeing the fruition of the research. If you start with how we got to MRI, that was a lot of work. There's progress in terms of getting the MRI to be a quicker study, because currently it's quite a long study, and particularly people who've got claustrophobia, they struggle with it sometimes. And people who've got electronic implants can't have an MRI, like a pacemaker. So sometimes we're left with that issue. You raised other forms of imaging. For example, there's something called positron emission tomography, or PET. And there is a type of PET scan known as a PSMA PET scan. And this picks up, think of it essentially as a PSA scan. It picks up where the PSA is coming from. In a prostate, there should just be PSA in the prostate. A PSMA scan might show that there's an accumulation of a lot of prostate in one part of the prostate, which might marry up with the MRI to tell us that that might be where the cancer is. More commonly, PSMA PET scan, though, is used for what's called staging. In other words, once we find the prostate cancer, we want to know, is it where we think it is, just in the prostate, or has it progressed beyond that side? And if it has progressed, where might it have gone? So the federal government had increased funding for this, which came about in July this year, for PSMA PET scans at diagnosis. And also, hopefully never, but some years later, if the prostate cancer comes back, it can be co-funded by Medicare once again. An extension of that through work that's primarily been done in Melbourne by Michael Hoffman, who's a nuclear medicine physician, and Declan Murphy, who's a urologist. They had funding to start doing PSMA PETs on a number of people, and they were very fortunate to be able to scan a whole bunch of people and therefore accumulate evidence on PSMA PET scan. And we are leading the world currently in PSMA PET scanning. Australian urologists and radiation oncologists are probably the ones using a PSMA PET scan the most when you compare even with US colleagues and those in Europe. So the extension of that was whether you can use the PSMA PET type technology to deliver therapy to areas where prostate cancer may have got to. Current thinking is that it is possible to deliver that, and there are trials being done to assess that. But in the world that comes before us, you could imagine a time when local treatment could be delivered intravenously. In other words, through this type of technology, it doesn't have to have spread beyond the prostate. It could be delivered as focal therapy into the prostate. And that's on the horizon for us, because if you look at your crystal ball, what you want to do is to be able to find your PSA, your prostate cancer, even without a blood test, preferably, just with some sort of Star Trek scanner, which could be a very simple MRI. It shows the spot. There are features on that spot that could be verified by another scan, like the PSMA PET scan. We may not even need to know how aggressive the prostate cancer is, because once we know it's there, if we've got effective treatment, we can then deliver that treatment, putting people like Tanya and myself out of business by some simple treatment that targets this thing, and off you go. It's all done. That would be an ideal world with minimal side effects. So without the side effects that surgery offers or the side effects that radiation therapy offers. When I was listening to Tanya just now, I was just thinking how lucky the average man with prostate cancer is as time goes by, because you've got these two amazing specialty groups intellectually competing for this disease, and each one trying to outdo each other. And you've heard Tanya outline the amazing technology they're using as they develop radiation therapy. And urologists are also trying to improve the way we take out the prostate so that we do very little damage to the structures nearby, which can lead to erectile dysfunction and urinary incontinence. And listening to you, Bernie, about all your tools that you're out there with PCFA, the one thing that you did cover, which is very important, something we've ignored collectively, is the psychological distress that these men and their families suffer, the counseling that's needed, the issues of sexual intimacy. We still are very basic in the way we deal with men's sexuality. We talk about their erections and forget that it can be so much more than their erectile function. and that men could have satisfying sexual activity without an erection, but they don't get the sexual counseling that they need in the community in general. So that's another area that I think PCFA is starting to grow interest in. So I thank you for your focus on that. So that's where I think, the future comes. It's about diagnosing it early without all the hassles and the complications that can come with the diagnostic tests as well as the treatment, and then delivering the man as pretty much as we found him without the side effects that the treatment can offer. We're very good at curing this disease when we find it, whether it's with radiation or surgery, but where we fall down still is side effects. And both sides are trying to work very hard to deliver our treatment and minimize the side effects.
Yeah, that's such an important point as well. I just had a little question onto this, Prem, about technology outside of medical technology. Like we talk about artificial intelligence and things like that. Do you think that will interplay in the future of your practice?
Yes, the short answer is artificial intelligence is affecting us already. If you look at what pathologists are doing, well, we start with the MRIs. Artificial intelligence is currently being used to read MRIs more and more reliably. So what studies are doing at the moment is getting 2 independent imaging specialists to read the MRI and then using artificial intelligence to see whether it can match up. And the early results are very promising. If you look at pathology where the specimen is removed either in a biopsy or the whole prostate, that is currently labor intensive and done by a pathologist who's trained in urology pathology. And that is also another area that pathology is using to use artificial intelligence to pick up the information more effectively and quickly and across the globe. I'm sure there are other areas. If you look at surgery, there are these models that can be generated so that while you're operating, you're also looking at a model of the cancer that was created from the imaging, showing where the tumor was. So when you're getting close to it, while you can't see inside the prostate, you can see it effectively because there's an image next to that telling you where everything is. So if you want to nerve spare, for example, and try and maintain good continence and erectile function, you just get better definition in that area. And I'm sure Tanya might have a comment about where artificial intelligence is sitting with radiotherapy, because I can't imagine it's not affecting that technology as well.
You mentioned Star Trek earlier, and it really is like we're turning science fiction into science fact with all these technologies. But turning it over to Tanya, same question, next 5 years, but from a radiation oncologist perspective, what do you think is going to come our way?
Yeah, look, I think in the radiotherapy realm, the PSMA PET that Prem was just talking about is going to just become more and more important and be used not only just in diagnosis but also in restaging, which we're now able to use thanks to the getting the Medicare rebate. So I talked about before, one of the sort of most common scenarios where we use radiotherapy is in the definitive setting when the prostate is still there. But the other important area that we use radiotherapy in is in the recurrence setting. So in men who've had surgery and had their prostate out, but in whom their PSA is going up again. And, in the past, without PSMA PET, we sort of hoped that the area where it might be was where the prostate was, or in the lymph glands in the pelvis, and sort of just treating people to try and mop up or get rid of any cancer cells that are left behind. But one of the fantastic advances with the PSMA PET is it's enabling us to detect at very small levels of cancer where the cancer sits if the PSA is going up after surgery, which is really enabling us to sort of target much better the patient who needs the radiotherapy in a salvage setting, but also exactly where the radiotherapy needs to go, and making that more effective. So I think that's really important, and that's something that's going to continue in the future. The other thing, along the lines sort of is the AI, but we certainly use AI is getting more and more used in radiotherapy in terms of generating plans, the radiotherapy plans with much quicker turnaround and perhaps better than what people planners can do. So there's a lot of AI used in radiotherapy planning and in the fusion of the MRI scans and the PET scans into the radiation planning systems, AI for that as well. And the other big advance, I think, which we'll see more and more, both in surgery and in radiotherapy, radiotherapy and impacting on how we decide about best treatments is in genetics and genetic analysis for patients. And there are a number of genetic tests that are starting to be used quite freely in the United States, which we don't have access to from a cost perspective here. But there are certain genetic profiling or sort of personalised medicine where we may better be able to detect the patients who don't need treatment or those that need escalated treatment. So those who have a higher risk of cancer recurrence after either surgery or radiotherapy, and trying to use that information to personalise treatment and increase treatment at the beginning, diagnosis. I guess in the next 5 years for radiotherapy, I guess you have to look at what all the trials are looking at the moment, because that's where we'll see our change in the next 5 to 10 years. And particularly in high-risk patients. So in high-risk, we do probably more high-risk patients come for radiotherapy than in the low-risk or intermediate risk setting. And that's because there is a high risk of there being cells away from the prostate. And so we know in that situation, having a combination of therapies where you get a whole body treatment, such as hormone therapy, which is called systemic therapy, in addition to the local therapy, which is either surgery or radiotherapy. So a combination of the two is often better than just the one. And as a standard of care for high-risk patients, for many years now, we've used a combination of sort of 6 to 18 months of hormones plus the targeted radiation. And all of our research a lot of our research at the moment is looking at trying to bring in other systemic therapies early. So hormone-based tablets such as abiraterone or enzalutamide or darolutamide, there's a large number of them, which we know are very effective when cancer's already spread into the bones or other places. So we're looking at bringing those drugs, which are very effective anti-cancer drugs, right up to the beginning at diagnosis and using that with radiotherapy and seeing if we use 3 modalities rather than 2, that we get better outcomes and more cures for these high-risk patients when we know there's a high risk of having disease away from the prostate. So I think there are 2 areas I think that we'll see change, both in the genetics and in adding in other treatments in addition to what we standardly use now.
So true personalised medicine.
I think so.
Great. So Bernie, I mean, this sounds quite incredible if you reflect on, I'm sorry to hear about your father 10 years ago, where we've come, but what can we do to marry what has just been talked about with Prem and Tanya? What can we do to marry that, to really change things for patients? To make sure that there's equity, to make sure that this is available to people, to make sure that patient voice is part of the multidisciplinary team, but also gets to government and other people like that, to make sure that Australia is the best place in the world to be treated. How do we get there in the next few years?
Yeah, we've got to continue clinical trials and continue research and continue these discoveries, but we've got to involve the patient as well and give them a voice and give them a say in that decision-making process, in advocating for them. We've got to, as organisations, as USANS, as RANSCAR and as PCFA and as other organisations, work together collaboratively, to advocate for these treatments to be standards of care where that's appropriate, and to get earlier access for people to these treatments where they most need them. So and access not only in metropolitan centres, but rural and regional and remote communities as well. Give people access and enable that. Enable people to do that. These research projects, these clinical trials, they provide hope where there wasn't hope before. So we need to be able to translate these things into actions, into meaningful things for people out there, and working together as we all do. Is an important part of that, and putting pressure on governments to make these things happen is very important. It's very important, what we're all here for, I believe.
Yeah. So, and you just mentioned the government, and we're currently the health technology assessment. So that's how the government decide what gets reimbursed and doesn't get reimbursed. There's still a big lag between regulatory approval by the Therapeutic Goods Administration and PBAC reimbursement, which is true access. So the HTA review is underway, and obviously the patient's got a voice. But you mentioned RRR, regional, rural, and I've just forgot, but
Remote.
And remote.
33% of patients. And with COVID has really given us all a crash course in digital literacy. So maybe this is a question for Prem, Bernie, and Penny. Is there stuff we can do like teletrials and other things to really connect this RRR group of patients with metropolitan standards of care? Maybe Prem, have you got any thoughts on that?
Yeah, I'm in Port Macquarie, New South Wales, so very much a rural practitioner. And we're lucky we've got great urological services here, including radiation oncology services. So we're doing well. I think where COVID has really helped us is, as I said from the start, this awareness issue and the use of technology. So if you come back to things like treatment access, yes, that can be delivered closer to home, but it does often require to travel if you don't have the services nearby. But the follow-up can be done in a co-managed fashion, either with someone like a prostate cancer support nurse and the GP, and telehealth connected with that. If you look at counseling services, where before it just wasn't going to happen, it was going to be done by phone and it wasn't a reality. Once it became a reality and it became a funded reality, then it does mean now that someone who's in a town of 100 people could get counseling services by telehealth. And more than likely, the patient, unless they are not that technologically literate, more than likely they have been starting to use Zoom or FaceTime or any number of these technologies, because a phone will give you that access. And that allows them to get very high quality resources. And they also have to go onto the internet and find, the PCFA website, and they'll find a ton of stuff there, or pick up the phone and speak to someone, and that immediately puts them in touch with a lot of the resources. So again, it comes back to increasing awareness.
Yeah, and Tanya, I mean, obviously you can't deliver radiation therapy via Zoom, but has it changed your world?
We can't deliver it by Zoom, absolutely. But, again, 10 years ago, patients had to travel a long way to come and have radiotherapy, and that probably influenced their choice in treatment, particularly when radiation was being delivered in 8 weeks, every day, Monday to Friday. It's a long time to be away from home. Whereas now, with the technological advances of being able to deliver treatment in a lot shorter period of time, and that has opened up more men rurally and remotely to the ability to have radiotherapy. But in addition to that, the two big private providers, Icon and Genesis in Australia, in the last 10 years have opened up a plethora of small but very good radiation oncology centres up and down the coast and around Australia in every state. And so the access to radiation therapy now compared to 10 years ago for patients who live in those 3 Rs is much, much better, and it means a lot less travel for a lot of patients. So I think that's probably the biggest advantage from a radiotherapy point of view.
Yeah, it's incredible. And then maybe one last question for Bernie, and then we're going to skip to the questions that we've had taken to us today. So Bernie, we've talked about patient accessing this information. How do we make sure they access the right information, the information versus disinformation in a world that everybody's got access to Dr. Google?
Yeah, it's a difficult one. We need to give them the evidence-based information upfront. So going to reliable sources and providing that at that initial point of contact is one of the most important things. So whether it's PCFA's resources or other resources like Prem's very good book, and Cancer Council's resources on prostate cancer, providing those at that initial point of contact, and then providing people with that second layer of support, where they can, advising where they should go to seek further information, and having that available and making that available. So we take many calls from people who are very much in that situation. They have being given, a small amount of information, and then they have trawled the internet and gone to so many different sources, and they come back very confused. So giving that very much comprehensive information at the start, but then also giving the opportunity to discuss their questions and concerns and point them in the right direction for further support, is an important part of that initial consultation, of that initial staging of the disease.
Yeah, and a follow-on question, which is a question about, there's maybe a bit of a thought that the information could be a bit reactive. What could we do about that? How can we make sure that the side effect the side effect information rather is more proactive than reactive? How do you think we can do that? And then I might ask Prem a specific question about this.
I could butt in there. I think it's a very easy one. In this country, we are very fortunate to have the PCFA. I always direct patients to your resources, because I think that rather than going to Facebook or any number of, did you know that there's this treatment in America that's going to cost me God knows what? I don't know why people feel that the thing they found on Facebook is the world's best kept secret and everyone else doesn't seem to know about it. They see a urologist and a radiation oncologist, they get good opinions from well-qualified people, and they're still looking for apricot kernels or, mountain salt or something like that. I have no idea why someone would do that. It maybe tells us that we're not giving them the information that they need. So in the way PCFA has handled this, I think, is it uses survivors as their core source of, what do you guys need? What do you guys wish you had? And then work from there. So I think the PCFA resources are the best. And that's why I would direct them to your resources first, and then they can work from there.
There is a specific question about hot flushes. Would you be able to address how you treat hot flushes?
Yeah,
I'm sure Tanya, do you want to go with this one?
Yeah, sure. So I think it as a radiation oncologist, hot flushes is something that we deal with every day, because 80% of men who have radiotherapy will have a period of hormone therapy as well, and hot flushes are a very common side effect of hormone therapy. And so men often having to deal with hot flushes for 12 months, 2 years, sometimes even longer. So in the most situations, we can manage to deal with hot flushes without using medicine, and just using conservative style approaches in terms of looser clothing, fans on at night, just being aware of when the hot flushes come, knowing that they don't last for very long, and explaining to men why they're getting them and what the cause of them is. But there are a couple of other pharmacotherapies that we can use, which are very effective, but like all drugs have some side effects of their own, so it's always weighing up the pros and the cons of adding another medicine in to treat a side effect of another medicine. But hormone-based therapy such as Androcur can be used in low doses for hot flushes that are very bothersome. And when I say bothersome enough that men actually don't want to be on the hormone therapy because they're really struggling with them, or they're waking them up a lot at night. And sometimes hot flushes are not the only side effect of hormone therapy, and there are many other side effects that men can suffer from. And one of them is low mood or altered mood. And so sometimes using an antidepressant that has a benefit in reduced sweating and helping to reduce hot flushes, but has the added benefit of also helping with low mood. Sometimes we use those as well, and they can be very effective in some men. So I think it's just about making people aware that what they are and how often they're likely to occur, and what's normal and what's not, knowing that the hormone therapy for a large number of people who are being treated curatively it's not a long-term problem as it is for men who obviously have incurable disease where we're on hormone therapy for a very long time. And then, as I said, picking those men who would like to do something about it and knowing that there are those options and talking to them about those. Great.
I'm glad you mentioned the antidepressants, because I think it's something, a lot of men feel a little bit ashamed of the talk of it, but they really can help. And the mental health, as Prem alluded to earlier, the mental health is as important, if not more important, isn't it, than the physical health. Prem, a question to you. So the last webinar, we talked a little bit about erectile dysfunction, but there's a specific question about protocols from the body of urologists, as you sound. Is there a protocol? Is it, and can you just talk a little bit about erectile dysfunction and how it could be harmonized potentially?
Yeah, I think the first thing about erectile dysfunction is to make sure we inquire from our men One of the mistakes we make is we look at a PSA result after treatment, for example, and it's usually, if successful, the PSA result is almost a 0 or as low as it can get. And you're happy about that, and you forget that, well, that's part of the issue. The second issue, if you talk about surgery, the second issue is whether they've regained their continence, the urinary function, and whether it's an acceptable level. And there can be distress from that. And the third issue, not necessarily in that order, but the third issue is obviously sexual dysfunction. I prefer to think of it as sexual dysfunction rather than erectile dysfunction, because while we focus on erections, some men, for example, will say, I can get an erection. It's relatively adequate for non-penetrative sex, but I can orgasm, for example, with that erection. And is that okay? Is that, you know, if that's what I'm doing, is that okay? And the answer is obviously it's okay if that's what you and your partner are happy with. If they want penetrative sex and they do need a firm erection, then it's very common to start using drugs like Viagra or Cialis, which are now available in generic form, on a daily basis for at least the first 12 months, because it improves blood flow into the penis and helps with recovery. That's often supplemented with other types of treatment. We can teach men how to self-inject their penis with a very small needle. Most men sort of recoil in horror when we suggest that. But if you're a diabetic and you're told that you need to inject yourself with insulin with exactly the same type of needle, you'd probably just accept it. You may not be happy about it, but you'd accept it. I always say to men, if they would like a firm erection, what they should do is try the treatment once or twice, because when they see the erection and can feel the erection and also expect the reliability from it, then they can decide about whether that little pinprick was worth or not. Because if they get a good erection that often they haven't had for a long time, even before their treatment, then they might feel that's worth doing. If that doesn't suffice, then often we can put in what's called a penile implant. It's hard to describe in words, but I often show them diagrams in a model where we put 2 little silicone inflatable cylinders into the penis, and it's driven by a hydraulic system to get them a very reliable erection. I guess most people, when they think of this, think of mechanical pictures, but it's not mechanical at all. It's built into the penis, and there's no mechanics on view. So it gives you a very reliable erection. But none of those decisions can be made without adequate counseling, because it does cover more, as I said, than the erection. And therefore, there needs to be a clear understanding about what we're trying to achieve. And for example, a man might be happy if they could just get an orgasm with a soft erection and forego the firmer erection. And you may recall when I said at the beginning, one of the counseling aspects was sexual intimacy counseling. And that's an important aspect of this particular discussion and this particular question.
I just think it's so wonderful that it's talked about, and again, men are talking about it. That's what we discussed at the last the last webinar. And again, I don't know how much it was talked about 5 or 10 years ago, but it just seems it's not it should not be a taboo. This is a human need, and with the fact that people are living so much longer and being cured of things like prostate cancer, it's very nice to hear that this is also being addressed.
And taboo topics are interesting, aren't they? Because if you look at young women who seek out breast implant surgery, for example, that's something they can't hide. If they wanted to have breast implants and after they've had them, it will be obvious to everyone who knows them. Yet amongst that peer group, it is an acceptable thing to do. And it is relatively well supported. It builds up self-esteem. Yet you look at the other end of the scale, you look at a male who's had prostate cancer treatment, or whichever treatment they may have had, they're very shy, and they're not going to be discussing their erectile dysfunction. They're not going to be wanting to seek out treatment because they think it's taboo. You know, they're older men. Why should they still want to be sexually active? Yet in my practice, because I do a lot of that sort of work, it's very common. And the first thing I need to get them to understand is it's got nothing to do with anyone else. And unlike the breast implant surgery in a young woman, if they've had penile implant surgery, no one will know except their sexual partner and themselves. So there's no need to discuss it with any number of people. They can keep it private between themselves and the treating doctors and get on with regaining the function that they seek.
Fantastic. Bernie, this is something Tanya mentioned earlier, but I just wanted to ask you about genetic testing, which again, we're understanding a little bit more, and we understand about BRCA and other things in the prostate, but how often do you address genetic testing in your daily work?
Increasingly so. So men are more aware that these types of technologies are out there, and certainly now with the addition of genetic testing for men who have metastatic castrate-resistant prostate cancer, where there's an MBS funded option for men to have that testing, we're increasingly receiving calls from men and their families, their partners, about what it's about, how to access it, and who do they talk about to get it. And I guess it's fantastic to see that's something that's out there. And I guess that there's off the back of that testing, there's actually been some drugs developed which can help men who have a BRCA mutation, and provide them with hope and another option after they've been through so much already. So it's fantastic to have those options there, and we increasingly talk about those things with people who call us.
Fantastic. Tanya, sorry, did you want to add?
I was going to say, very much a part of, because we're finding out more and more about genetics, and BRCA1, BRCA2 are only one such mutation, but it's certainly very much an important part of every first clinical consult with, whether it's with your surgeon or with the radiation oncologist, about getting a good family history of not only prostate cancer, but also breast cancer and ovarian cancer and other cancers within the family, so that we can highlight individual families and members where genetic testing might be worthwhile, way before we get to the point where the person has metastatic disease and looking for different treatments. Just helping to their family in terms of coming up with what's the right screening for their family if they do have a mutation. So I think it's sort of certainly become much more a standard of care in terms of questioning for every prostate cancer patient who comes through the door.
And so what about genetic counselling? Sorry, Prem, I'll come back to you in 2 seconds. What about genetic counselling then? If you're finding...
So in men, for example, if somebody comes to see me and they've got a couple of brothers who've had prostate cancer and an uncle who's had prostate cancer, then I'll talk about what that means and what it would mean if they do have a BRCA mutation, what it means to them personally and what it means to their children in terms of screening for other cancers as well as prostate cancer. And then if it's something that they would like to know more about, then we have a very good genetics service in Queensland. So I would then refer to our genetics counsellors, and then they go and see that team, have a more in-depth discussion about it, and then if they elect to go ahead with the testing, then the testing's done through the genetics team. So you can get genetic testing done and just pay for it, or online even, but I think the counselling component of it and knowing the implications of having a positive test are really important, and so I certainly do encourage people to go through our genetics counselling service rather than just paying for it offline.
Sorry, Prem, did you want to?
Yeah, no, I just wanted to add to what Tanya was saying along those lines, that for the men who are listening, for example, to this video cast, that it's important that they discuss it with their family if they're able to, because the next generation are potentially affected by prostate cancer. It is a genetic disease in many families. And the BRCA genes that we've been talking about are also relevant to breast cancer in women. So a breast cancer history in a family coupled with a prostate cancer history in the men is also an alarm bell to check for genetic testing. But the simplest way is to let people know and make sure that the men in the family plan to get a PSA test earlier than the age of 50, and at least keep it on the radar when they see their GP that it's something they need to track as a potential risk.
Fantastic. Okay, we might just finish on a couple of questions again about regional, rural and remote, RRR. And I've got a question for Bernie specifically here about, do you know the latest figures on incidence and mortality differences between men in regional areas in the city, and are there any reasons for that?
Yes, certainly. The mortality rate we do know for men in regional and remote communities is 24% higher for men in those regional and remote, regional and rural communities compared with their urban counterparts. So significant differences there. And I guess part of that is, you know, while there's been all these advances in researchers and treatments developed, you know, there's still not that equitable access to that across the population. And I guess when you couple that with you know, access to PSA testing and an awareness of the importance of PSA testing and looking after your general health and visiting your general practitioner to have that discussion, then that leads to, you know, men being diagnosed at later stages. And we see that from the Stargate data in many communities, regional and remote communities. Men are increasingly being diagnosed at later stages of the disease, where the disease is harder to treat. So it's important for us to understand that data and to work with government to develop policies to target those areas. But it's also important for us to help people in those regional, remote communities, rural communities, to understand their individual risks. So it helps us, that sort of data helps us inform campaigns and awareness activities in those areas. So yeah, and I guess at an individual level, you know, we can target men with that messaging and make that appropriate by being more aware of that.
Okay, that's a great answer. And then maybe a question to Prem and then Tanya. How do we get more specialists then? And you say, I know you're important, Corey, Prem, but how do we get more specialists, do you think, into these areas physically? We start with urology, and then I might go to Tanya as the final question of the day.
Yeah, it's a issue that I think all medical groups, not just specialist groups, but primary care as well, deal with. You've got a few issues. One is you need to have professional satisfaction with the work you do. So sometimes coming up to a rural or remote area gives you that, because it expands your scope of practice to do more than you envisaged. There might be family lifestyle issues that you may be from a regional area and be keen to get back to a regional area. With that comes spousal issues. You know, your partner needs to feel like they're going to fit in, and they will often have a career of their own, and you need to be able to recruit them into the area. So we're quite lucky in a town like Port Macquarie. We have a lot of partnered husband and wife type partners where they're both medicos, and they can fit in very nicely, because we always need anyone of any caliber. But you also need infrastructure. So people will come. For example, when I first came here 25 years ago, I was the first urologist here, and I used to have to send all my radiotherapy patients to Newcastle, which is about, at that time, was about a 3-hour drive. It's a bit shorter now. And as Tanya says, you know, I was operating on more people because they just didn't want to go to Newcastle and stay there for 8 weeks, which is what the time frame was. As soon as we got our radiation oncology service set up here, it shifted, you know, and people would prefer to have radiotherapy because they could at least have an even choice of making a decision. And I think that was good things, but that was resource. And along with that department then came, I think, about 4 radiation oncologists. Before there were none here. And that's been growing, just like our urology department has grown into 4 and about to grow into 5. Once we get that, then we get more and more resources. Then people feel there's a bit of a team. And when you work within a team, you feel that collaborative, you know, important structure as part of a team. We have our multidisciplinary teams now. We connect with other towns, and we lead that. So you need the resources. If you specifically talk about urology in regional areas, then robotic surgery is very much part of that now. The younger urologists who come out would like to continue their robotic skills. Victoria recently has started putting robotic surgery into regional towns to actually attract people, because the Victorian government saw that as an opportunity to get people into regional areas. Because you can imagine if they put the robotic surgery into big city hospitals, which is clearly where they need it as well, then the younger surgeons won't go out to regional areas, and it becomes a vicious circle. If you put them into regional areas and start doing that, and I believe we might be getting one in Newcastle in the near future in a public hospital. We've got one here in the private hospital, but clearly robotic surgery in the public system is what we really need across the country. so that people can get equitable services. So once you have the resources, and that infrastructure extends to other things like good schools and communities that you can bring up children in. So it's a huge issue, but it's multifactorial, and it's not just in medicine.
Okay, thank you, Prem. And then finally, Tanya, anything else to say on that? You mentioned Genesis and other radiation providers. Any other comments for the final word on how we get more radiation oncology specialists?
Well, I mean, I guess just looking in Queensland, when I first started, 20 or more years ago, we had 3 centres in Brisbane and we had 1 in Townsville for the entire of Queensland. We now have 1 at the Sunshine Coast, 1 at the Gold Coast, 1 in Toowoomba. We have it at Hervey Bay. We have it at Bundaberg. We have it at Rockhampton. We have it at Mackay. We have it in Townsville. We have it in Cairns. So we have just this plethora of good radiation oncology centres, albeit small, up and down the coast. And all of those radiation oncology centres have at least 2 or 3 radiation oncologists working there. So there's been a big change in having radiation oncology services and radiation oncologists within, and they're in the sort of the bigger towns rurally and remotely. So we clearly don't have anything way out west, but I think we've made such massive improvements in access in the last 5 to 10 years, which is fantastic.
Yeah, it is true. Okay, the only thing I have to do now is thank you all. Thank you, Prem. Thank you, Bernie. Thank you, Tanya. Thank you to the community support in 2022. This is the last webinar of the year, and then we're in 2023. Just a reminder that people can call 1-800-22-0099 for information or advice, or go to the website www.pcfa.org.au to learn more. We do look forward to seeing you in 2023 for all new conversations on prostate cancer. Please share this, please like it, please comment on it. Please talk about this. As more we talk about, the better. And again, thank you to this esteemed panel. Thank you to PCFA. And enjoy the rest of the year, everybody. And we'll see you in 2023. Thank you.
Thanks, everyone.
Thank you.
Thank you.